So I guess to start, how many people here are familiar with the term secondary use of data? Okay, so that's really what I'm going to be talking about. Just to avoid confusion, this fancy title is a way of hiding the fact that I'm talking about secondary use of data, and we'll jump right into that. First of all, what is it? Talk about some opportunities and barriers, look at future directions. So the first about 2/3 of this talk will be kind of giving my view of overview of where we're at in the healthcare industry, with a focus on providers, but kind of healthcare in general. So when I say healthcare in general, I mean not just providers, but also payers and pharma, all having interest in healthcare data and how to use it. And then also, in the introduction, Mark mentioned that I'm presenting next month on a research study that is in itself an example of some secondary use of data. And so I'm going to spend about the last third of the presentation providing some preliminary results from that as an example of a secondary use of data, and briefly mentioning some of the issues around secondary use of data, and also why I think secondary use of data can really have some beneficial uses. So first of all, what is secondary use of data? Well, here's a really long explanation that was published a few years ago in Jemaya, and this was based on a focus group kind of meeting that they had with a bunch of grand poobahs of the healthcare industry. And it goes on, non-direct care use of personal health informatics, including but not limited to blah, 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 a bunch of stuff, okay? So non-direct care use, so that means you're not using it in the process of delivering care, okay? And it's personal health information, so that means it's something that relates to care, relates to health information, right? So a really short way, an easier way of saying this that I picked up from a healthcare-related website is any usage of personal and health information other than the reason it was collected. Okay, so that's why it's secondary, right? So that's really pretty simple, and I think much easier to understand than the first definition. But the first definition is sort of the precise scientific one, and since I'm an academic, I'm used to having to give the precise scientific ones. So what's important here, though, is that because we're dealing with healthcare data, there's a lot of reasons to be very careful about how that data is then used in the secondary use. Okay.
What about sort of netherworld? So, for instance, if meaningful use required that we collect the data now and immediately send some of it to the government for research purposes, for whatever purposes, quality improvement, is that secondary use of data? I mean, sure, it's secondary, but it's actually one of the driving reasons why you're collecting some of that information. And it's immediate. It's not like next Thursday after you've used the data for your own work. Just a question.
Yeah, so that's a great segue to my next slide.
Excellent, thank you.
Thank you. So part of what's driving secondary use is indeed regulatory reasons for collecting data. The quick answer that I would say to that is if it's data that you weren't gathering as part of the care, if it wasn't actually related back to a patient, then we wouldn't think of it as secondary use. That might just be regulatory data about how you're running your operations. Okay. If indeed it was data about the patient that you had that was generated in the course of the treatment, that is also still being gathered and passed along. Then any other further use of it is secondary use. Okay. That's where I would make that distinction. Now, I don't know if it's terribly important to get that fine of a distinction per se, but that's where I would make a distinction. But one way of looking at this is that part of what's really driving this, and I think this is important to kind of put this in the big picture, why am I here talking about this today? Okay. And a lot of this is driven by the great amount of funding that's going and interest that's going into increasing the level of automation, the level of IT in healthcare. So we have a lot of people putting in electronic health records, enterprise resource planning systems, So that might be improving the efficiency of your hospital's purchasing systems, billing systems, other kinds of business systems. A lot of privacy and security issues that go around that. So if we look at kind of backward looking at making sure that all your systems are HIPAA compliant. More forward looking, with the government funding, a lot more interest now in interoperability, connectivity, growth of health information exchanges, personal health records, driving more towards business intelligence solutions. The Recovery Act regulations and standards are now requiring collaboration among all the sectors for different kinds of data. And this is really then what drives that secondary use of data. And part of the logic behind all of this, and this is what I think is important to keep in mind, is that ultimately this is designed to have better health outcomes at lower cost. Okay? The whole point of this really is to bend the cost curve, to get better health outcomes at a lower cost. And the idea being that you can't accomplish that only through optimization at a single facility through just looking at your own data, that there is a need to be able to provide data that can look at things beyond just the walls of one institution. Okay? So that's part of why we now get into these issues about how different organizations need to be able to share data with each other, or that it may be that people beyond one organization need to be able to look at data. So other people that are researchers being able to look at data that may have been created by somebody other than themselves. And so that's really what's driving this secondary use. Some of the real challenges we have then is that we really need to have some transparency around this use. And so this is, again, from that Jemiah article where this was a few years ago, and so these are some of the ongoing challenges that, some of which are being addressed in different ways, some of them better than others. But what kinds of policy issues need to be addressed, what kinds of infrastructure need to be addressed. One, this is sensitive data, right? So we need some transparency about how it's used, right? There's ethical issues about if somebody was in a research study, they agreed to be a participant in that study, but does that mean that they agree that their data can be used for other reasons? Okay, so that's where we need transparency about these things. And a shift in thinking that would really support this is away from the concept of who owns data to the concept of control of data. And so moving from a concept of one person owns data and we hold on to it, to more a concept of somebody has control or governance over data, that then it can be shared, but you have strict access controls to it, control how it's used. Okay. Now, a parallel to this, and it's not a perfect parallel, but would be like in other industries, the way this kind of thing is handled is, let's say, the direct mail industry. Okay, this is an area where there's a huge secondary use of data. Okay, now not by this definition, but let's say that I have a very valuable mailing list. Like I'm an organization and I know who all my members are, right? And I want to maintain control of my membership list, right? But I also want to make some money off of my membership list. So how I can do that without selling my membership, or how I can sell my membership list without giving up control or ownership of it, right? So this kind of a concept is I rent it, right? So I let somebody, I send one mailing to everybody on that list. They never actually see who the members are. It's just slapped on there as a list of address labels. If my members of my organization respond favorably, then they now have a new relationship with this other organization. Okay. It's not a perfect parallel, but you can see how there's ways that a set of data can be provided access to, can be used without actually giving up the ownership, without actually giving up the control of it, right? So those kinds of models, thinking beyond just like you either have the data or you don't. Right? How are ways that we can share data? So obviously a lot of privacy policy, security issues, that's an example of something different than just all or nothing. And getting back to that question of, how do we get patients, how do we get individuals to feel comfortable, then I think there is a lot of public awareness issues around benefits and challenges. Okay, so I think that is an important part of this as well. If we really do see that there are long-term benefits for the secondary use of data, then it's incumbent to educate the public about that, to help make sure that there really are the right controls there, that we're using this data ethically, and that then people understand that there are benefits out of that. Yes, sir.
Can I ask you, can you pull back that previous slide? What you list here is a problem of all kinds of house. And what puzzles me, and it seems to be ignored since the last 10 years, is the issue of decontextualization. That means that if you are going to use secondary use data for secondary use, you also lose the context. And I know that the holy grail of medical informatics is to have data decontextualized. However, too many researchers, amongst others me, argue that it is a grave sin to just take data out of the context and just put them to use for other purposes. Namely because of the purpose of collecting them originally, and certainly in an electronic health record.
Could we have you repeat the question, please?
Yeah, I will as soon as the question's over. Thank you for the reminder.
But the issue is at hand. The issue is at hand. Why do you not list that as one of the challenges to the research? Because it is an ongoing discussion. Otherwise, the whole system of how it could be used up to the upper level.
Yeah, right. So one of the questions was that
based on quicksand.
Yeah, the reason I didn't list it is just they didn't list it, so I was taking these challenges from what was trying to more faithfully summarize what these folks listed. But to summarize the question is that one of the challenges with secondary use of data is if the data has been decontextualized, then that limits its usefulness from a research standpoint. And so the question was that the gentleman who asked the question used that as a significant limitation of the secondary use of data. So the question was, why isn't that up here? But as just a more of a general point, what I would say is that I think that the best practices for data is de-identification, and de-identification does not have to decontextualize. And so there's a question of how much context has to be taken out in order to actually maintain privacy of data and to avoid being able to identify an individual person as that person. And so this does get back to issues of how do we develop secure data stores for data and allow researchers to get the right kinds of summaries back out. And I would say that that's a very complex data architecture question that we will continue to struggle with. But I don't think that that by any means eliminates the entire enterprise. I think that there are certainly questions that can be answered, research questions that can be answered, and I think that there are data governance structures that can be created that can allow you to protect privacy without decontextualizing the data to such an extent that you can no longer do meaningful research. And what I would say is that absolutely is, if we drill down on that question of privacy policies and security, that would be how do we have privacy, how do we address privacy and still have meaningful use of the data. So bringing this a little bit more current, PricewaterhouseCoopers did a survey about 18 months ago of a number of folks in the pharma, life sciences, healthcare, payer and providers industry, and looking at the sort of state of secondary use of data. And some common themes that they had was one, most organizations that they surveyed were indeed making some use of secondary data. And here on the next slide, I'll follow up with more detail of what they found those uses were. It's primarily quality management. And that the primary driver as to whether an organization was doing it or not was whether they had adopted, or to what extent they had adopted, electronic health records. So not too surprising from that standpoint that electronic health records is basically the key enabler that gives us the most detail in a format that's most readily available to make meaningful inferences. And so as we see more and more adoption of electronic health records, then we're going to be in a position to do more and more meaningful secondary analysis. So some of the key challenges then is implementing the same challenges that go with the implementation of electronic health records, which is basically access for the technology. You know, how do we get these things, and access can mean all sorts of different resources in terms of in terms of money, in terms of people, in terms of how you can implement the software, how are you going to get this deployed along large complex work systems, how are you going to get this put in front of a provider at the time that they're actually providing care to an individual. Then concerns about the potential ramifications of how do we secure this data. So the same kinds of things I just talked about with privacy, confidentiality. And then the most common problems are the insufficiency of detail or the timeliness, which gets back to, in many cases, we do have systems that they might be able to get some of the data they're interested in. It's either rolled up in some way that maybe we're looking at stuff that happened a month ago, or it's not detailed enough so we can see in aggregate what our patient mortality was, but we can't go back and see, well, what was the detail about tie it back to this kind of treatment per patient. All we can say is in aggregate we had this much of this kind of treatments, this kind of mortality. That doesn't give us enough detail to then, that's a decontextualized setting, so we can't go back and look at the individual histories well enough, right? So that would be the kinds of difficulties. As electronic health records are rolled out more, then we can get the detailed data, the patient histories, as we have more and more filling in more and more data about a patient, and particularly about their history, capturing more and more of their interactions with the healthcare system in total. Then that provides a much richer set of variables to be able to nail down and understand what really is causing differences in outcomes. As we were just talking about, there really is some issues about how this data is stored if we're going to be able to get at the secondary use. Okay. This, if I look at the parallels of how people have done data warehousing in other industries, within a single organization, if you want to do a data warehouse to look at analysis of data, you need something other than your operational data store. Okay, the system that you have for running your business is almost never the same system that you have for analyzing your business. Okay? So the systems that we have for capturing for the transactions for our healthcare, in other words, our electronic health record systems, are not going to be the same systems that are the best systems for analyzing the data. Yes, sir.
Is that an intrinsic problem, or is that just because the people that were designing the operating system didn't think enough about the aggregation later on? Is it just because they didn't, or is there something intrinsic about the fact that you have to have two systems?
It's an intrinsic problem. And the reason it's an intrinsic problem is that when you have a transaction-based system, you have lots of people that are updating things. So you have, like, if you think about a patient record, just a real simple example. Okay, the patient arrives, you have an admission process. Okay, you're writing the record. Then you have a bunch of orders that go against that record, right? Okay, so you have to optimize for that. You have to be able to handle that. You can't have the system saying, wait, hold on, I need to reindex this table. Right, okay. When you're doing analysis, there's very little update to the table. right? It's fine to update it once a day with yesterday's data, right? We don't really need to analyze. In fact, we don't really want to analyze patient outcomes till they've had an outcome, right? So it's just fine. I mean, we don't want to do our analysis. We don't want our analysis database to be updating real time, because then you have a problem called twinkling, which is you think you have a total and then you go down to the drill down and it's different because it just changed, because it was updated with some new patient that just, right? So you actually need to know that it's like everything through the end of last week, or everything through last night, and then, you know, tomorrow I can do everything through last night, right? And so there you are doing a lot of hits to read a database, to read a data store, but your updates only happen like once a day. And so that's you're optimizing for a different question, okay? One of them, you have lots of reads and writes and updates and all sorts of things going on, and you need a really good throughput for that. The other one just updates very rarely, but you have lots of different ways. You need to be able to access the data from lots of different dimensions, lots of different ways, and so that's different. Then when we add to it, we have this other issue for secondary use of data, which is we need ways to protect patient anonymity that don't decontextualize the data so much to make it worthless. Okay? And so that's a completely, you know, that's a different challenge, right? Which we don't have, and we have the opposite. If we have a transactional electronic health record, we absolutely, what's really critical there is we don't want any data to be decontextualized from the patient, right? You want to make sure when the lab sample goes to the lab that you never lose track of which patient that lab sample was for. Because if you do, then the lab sample is meaningless. Okay? You know, you absolutely don't want to make sure that the medication order doesn't lose track of which patient it's for, right? Because as soon as you do, it's meaningless, right? So you have to make sure that everything that happens is kept very close track back to a patient. So it's a very different problem. Okay, so to kind of close up on the where are we now kind of question, health information exchanges are an important enabling bit of infrastructure for secondary use of data. So they're not themselves per se a secondary use of data, although they, you know, in some cases maybe that you're sending off data to them to enable that. But I just wanted to show you, this was a real recent study from eHealth Initiative, and just to show these are proliferating like wildfire. So there's a lot of them. If you drill into the website for the study, they have some real concerns about the sustainability of the business models of a number of them, which I think is a legitimate issue. I think that probably we're going to see a bunch of these. There's still a lot of experimentation going on with this, and I think we'll see consolidation in the long run. There's a lot of economies of scale to be experienced with this.
Yeah. It's not really a second use of primary data, so that if I'm in a car crash in Miami, then you need a separate system that's able to export that data in some sort of standard national format, so that then when I receive follow-up care somewhere else, they can download that from some sort of cloud of information, because otherwise it's a complete waste of time when I have to go back through the entire process of explaining what happened last week in my car crash in Miami to my primary care doctor.
That's a very good way to put it.
Which
yeah.
is a complete waste of healthcare dollars.
Yeah, that's a good way to put it. Yeah. So it's not, and that's also where it enables secondary use.
That's not really secondary use because it doesn't have the definition of secondary use because it is in the primary care interest of me.
Exactly. So it's designed to solve a different problem, but it also really enables secondary use. But thank you for clarifying that, because the purpose of it really is to further primary use.
Right. So that's why I think it's a violation of your definition.
No, exactly. But that's right, and that's where I'm saying this is not secondary use, but it's a key enabler for secondary use because it's driving standardization of data. And so one of the huge issues that you have with secondary use of data as you try to combine data from more than one system, even if people were using, they both have Epic, okay, then one person said, well, we're going to use this field this way, and another person said, another organization, we're going to use this field this way, right? And so just getting, one of the things that happens is when you have HIE initiatives, is you're more likely to get standard use of data. The process of an organization, of a provider mapping their data up to the HIE data model drives more standardization. If I'm interested in secondary use of data, if I can go to an HIE and say, from a government standpoint, I would like to get data about patients that have X condition, right, then two good things can happen. One is there's a larger population that I might draw from rather than going around separately to 5 different providers that might have been already in that exchange. And then the second thing is that data is already standardized in some way. So that's what I mean by it's an enabler, and I'm glad you helped clarify that. Yes, sir.
One of the things I've sort of seen in the area that I work is that dividing these things up by state borders is a distortion of reality. Somebody gets their care, lives in northern New Jersey but gets their care in New York City. What happens to the data? It would make more sense to organize it around population centers or around patterns of care. And is this sort of fixed because of the funding, the way that this works? Is that why it's organized this way?
I don't know. That's a very good question. So that's just how they surveyed it, and I don't know if how many of these initiatives cross state borders. That's a very good question.
Although I bet there is some kind of state funding, like even the way they set up these regional extension centers have been, state by state, and in a way that's sort of weird because most people in Philadelphia, the issue is going to be Philadelphia and South Jersey, not Philadelphia and Pittsburgh.
Exactly.
So.
Yeah, no, it's a great point, and this also gets back to, what are our challenges? Yeah, I mean, so it's and that's just another distortion. And I think, again, that's where ultimately I think there is room for a lot of rationalization here because, there's going to be some areas where maybe the state does make sense, but then, some states can support a lot, but then there's other areas where it's not going to make sense, and it makes a lot more sense for 3 or 4 states to band together and have something. Or it makes sense for it to be the Philadelphia region, right? That makes a lot more sense. So, yeah. But I think that just the nature of what is trying to be accomplished here, that these will end up, unless there's regulatory reasons keeping them from doing it, that I think these will end up consolidating. But this is, in terms of secondary use of data, this is an important enabler along that chain, as well as something that helps from a primary use of data as well. Okay, so in terms of what people are doing now, where they're moving with secondary use, I mentioned that I would get to this a little bit more. So this is the last slide on secondary use before I get to my example. Okay, so today, over here on the bottom, down on the bottom right, is what most people are doing today. So this is the really high use, current use. The highest areas of secondary use today, and this again was the survey PricewaterhouseCoopers did, is in quality monitoring, reporting, identifying use of quality improvement. So this again is largely focused around a single organization using it to monitor their own quality progress. Okay. And that's what the survey found that most organizations are doing, which is good, but then there's a lot of other things that we can move forward to in the future. Up in the middle of the top, something else that we have that's also going on today, but I think will be really high interest in the future, is identifying evidence-based best practices. Okay, so a lot of the evidence-based care guidelines we have today are based on clinical trials, clinical studies, then the other idea here is that the promise that we have here, or the hope is that we can also look at actual outcomes from secondary use of data. And so this is a real opportunity. That ties in then with improving patient safety, disease case care management, analyzing and managing finances. That's a little bit more in the middle there. Some other things where there's lower levels of interest, but that can also be done, include things like even identifying candidates for clinical trials or personalized medicine. So these are things that I would say are way down the road, but could also be done. I think we've got a lot of other lower hanging fruit first, but you can see that there's a lot of different things that could happen. Yes, sir.
So, pardon my being late, I just finished coming, but if you're using the electronic health record as the point of entry for your patient information,
Mm-hmm.
and then you're going to be feeding that into your HIE or however you're going to collaborate, if you've got all kinds of different potential people putting that information in, i.e. residents and fellows and attendings and people who may have been educated in data governance, but a lot of people who probably haven't, how do you ensure that the data is clean?
Well, there's a kind of a tenet in data management that says the more data you have, the more of a data quality issue that you have. So the more data you have, the more bad data that you have as well. And so you never have clean data. So this is a perpetual issue. And I think that's one of the major challenges that you have with any kind of secondary use of data, but any kind of primary use of data. And part of the way that happens is that when you do have any kind of reporting that happens off of data, the more that essentially what has occurred in other industries is that when you give reporting tools to people that are closer to the entry of the data, that's what drives data. That's what reduces data entry errors or increases consistency of data entry. So if we call it business intelligence or decision support or whatever you want to call it, but basically if the people who are entering data actually see what it looks like on the other end, if they have reports that come out, if their compensation is tied to it, there's like all sorts of things that happen that then start to set up reasons why they then have an incentive to get the data entry correct. It also though takes that's sort of the carrot. Then there's also the stick, okay, which is you have somebody who's your data compliance manager, or whatever, who runs certain reports, and you find out that you have a problem with this kind of field being always wrong, and so then you train people, okay, you got to get this one right. The other thing you do is you look for ways that the systems can automatically collect data for you. Okay, I think this is also where, when you look through the meaningful use guidelines, that you see that there's more and more use, so that then, for the example I'm going to go into here is a system where they're using CPOE. So if you have computerized physician or provider order entry, then you're now starting to standardize that order entry. Then that's going to be more likely to be done in a way as compared to notes about what somebody did as an order, right? So then as you automate more of the process in many ways, that starts to get more consistent data. So it is a constant issue. And what I would say, though, is that the data that's in the system and that was entered into the system originally is more likely to be correct, and you have more opportunities to help guide somebody towards being correct than you will ever have from something that was entered on a sheet of paper, scanned in, and some attempt made to turn it into analyzable data.
I was just going to add, one of the things we can do, and Bob does now, is report on the inconsistency of the data.
Right. Yeah. And it's a constant battle. It's you'll run that report, and then everybody will work for a while on squashing the getting the error rate down to 0 or the compliance rate up to 100 or whatever. You have some target, and you make somebody and then you forget about it a little while, and you have a problem. Or hopefully you figure out why there's a screen that's poorly designed so that people are but that's always a challenge with any computer system. That's a good point. I mean, this is an inevitable issue with any computerization. And I think what we can strive for, though, is to get the really important stuff consistent. And I think that's, you just keep picking what's the next field that's most important to get right. Let's get that right. Let's make sure the system makes it as easy as possible to get right. Okay, we got that one right. What's the next one? And move on from there.
At Mount Sinai Hospital in New York, they did an analysis of their data, and they found 7,000 people who left the hospital dead and came back alive. They found 7,000 who came into the hospital dead, were not resuscitated, but somehow left the hospital alive. And this is just their own data. And they found 100,000 people who were born before they were dead, dead before they were born and vice versa. So the errors out there are simply stunning.
Yeah, I mean, so, and part of what happens is right now we're really good about the closer the data is to a payment stream, then the more accurate it tends to be as well. That's another truism. So, let me jump into an example, and I ran into all these same issues when I was analyzing this data. So I have an example of looking at electronic medical records and tying this back to evidence-based medicine. Kind of to set this up, was interested in this relationship, or this is kind of the relationship we're getting at, in relation to electronic medical records and secondary use of this data, and then how it relates back to evidence-based care protocols. And I just want to stress kind of here from the beginning that evidence-based care protocols come from lots of places, not just secondary use of data. So I'm not in any means saying that. I mean, a lot of them are from clinical trials, in some cases, just from our best practices. They're from lots of different places, so it's not just secondary use of data by any means, and that might even be the minority in many situations. So I didn't want to. I do want to just say that's part of what can happen. It may be a growing part of what's happening, but it's certainly not the only cycle here. In the example that I'm going through in the study that I've been involved in, we had all of the encounters from an emergency room for about 11 months. So a bunch of electronic medical records, and then we're making secondary use of that data to study some stuff. So one of the key things that happened first was the de-identification process. So I know some things about these patients. I know their age, gender, and what the acuity level was when they entered the hospital, what their chief complaint was. That's about it. I really wish I knew some things like what zip code they had come from, so I could have an idea of their socioeconomic status. I really wish I knew what their genome was. There's lots of other things I wish I knew, right? So I could rule out all sorts of variation, right? In the perfect study, right? But so there's a de-identification process, right? So we can argue, whether there's lots of other stuff that would be great to know, right? But I don't know, and actually the hospital didn't know either. So, but that's part of the process that went to that secondary use. Okay. And in this case, what I'm studying actually, and where this evidence-based care protocols went into this evidence-based, into the electronic medical records, is that this facility was using not only CPOEs, but also had care sets. They had a history of using care sets on paper, and then when they implemented their CPOE, they switched to on the screen. And so what this looks like is that in the emergency room, when the provider, it was almost always a physician, but it could have been a nurse in rare cases doing it. But when the physician was entering an order, they had the opportunity to either just pick an order off of a long list of orders, or just get an order set that would say, okay, this patient has this chief complaint, here's what the order sets are for that chief complaint. So let's look at this order set, and here's the recommended list. So that recommended list is based off of evidence-based care protocols. Okay, so it's based off of, or it's based off of some kind of set of best practices based off of, and from looking at it, they had gotten these care sets from somewhere else, customized them from a provider that, third party that provides them, and then customized them for stuff that they did at their facility. Okay. So what we were interested in, so again, I just want to stress, this, I'm providing this example for two reasons. One is that this is an example of secondary use of data, right? Okay, I'm a researcher using clinical data for non-clinical reasons, okay? And then the second reason is that showing how evidence-based care, how that relates back through these medical records, electronic medical records. Okay. So this setting was emergency department in a large southeastern U.S. city. As I mentioned, they have CPOEs with standard care sets at about 11 months. We focused on emergency room patients that had a chief complaint of abdominal pain that wasn't pregnancy related and wasn't like a wound. So it's just, I have a pain in my stomach. And the reason we chose that was the idea was that this was a very ambiguous kind of diagnosis. So there could be lots of different reasons, and so this from a kind of a complex knowledge kind of diagnosis issue. And then we were looking at all of the different orders that went to all the diagnostic orders. And we were looking at the ordering patterns for the diagnostic orders. For IRB compliance and HIPAA compliance, we had this depersonalization that I mentioned. And then something else clever that we did to get the IRB happy was we shifted the dates. So I know the date sequence that the patients arrived in, and I know the date sequence for the orders, and I know the time of day they arrived and the day of the week. And I know that I have like an 11th month period, but I don't actually know what the starting date for that was. So I know it was somewhere like in January, but I don't know what day.
Is the identification at the level of the patient
Yes.
or at the level of the encounter? So
Well, it's actually at the level of the whole data set. So
if a patient was in the ER and then 3 months later they were in the ER, you have the same identifier for that
yes,
patient?
I have the same identifier. I have the same fake identifier for that patient. Yeah.
That's
So I can't
very
actually.
key point.
Yeah. So I can't actually tell if that patient arrived more than once in my data set.
And you alter just the day and the month?
It's just actually the whole thing was shifted
Shifted how much?
by a day or
Okay.
by some unknown number of days.
Well, I'm concerned about weather and,
Actually, I think it was by 7 days. I think it was just because I think I still know the day of the week.
Okay.
Was that what your concern was?
No, it was more on allergies and weather events.
Oh, right.
And stuff
Right.
like that.
Yeah. It was it wasn't shifted like a whole season. Okay. Yeah. No, it was at most like a week. So, but basically that was the idea. So I thought that was even more extreme than needed, but I did like the concept because and I think the idea is not like that we as researchers would have any real reason that we were going to try to de-identify these people, but the idea is like if somehow our data set was compromised and got out into the wild, and somebody else who had some, for whatever reason, was really, really motivated to try to match up this data with some person that they knew because they figured out what hospital it was, had been in that hospital sometime, could they figure out who it was, that this would make it harder.
If all the data are shifted 1 month earlier or later, then nothing's been changed. I mean, all you do is put in a week deflator or something.
Yeah,
We
well,
got
as I
a
said-
random offset.
Yeah, exactly. So, but anyway.
What do you do if you find in your data something that you have to, that cause you to go back to the individual patient because of a certain medical condition that would have emerged from the pattern?
Well, we can't answer that question. I mean, and we had a very specific question, which I'll move to now since I'm running out of time. But no, so this data we got for a very specific question, and there would be other questions we flatly couldn't answer it. But for this question, what we were interested in is the impact of physicians using the computerized, the CPOE care stats.
What is currently then the status of observational databases in the US? The current status of the observational databases.
What do you mean by that?
Are there any differences between Europe and the United States?
I don't know. I mean, I know that in Europe that it would be even harder to get any data like this.
We maintain for 20 years an observational database that takes all medical data and electronic health records from primary care patients. We have ways of putting the data in the personal data in escrow.
Right. So yeah.
Then we use that data for all kinds of purposes.
Right. Yes. Since if you have a single provider and a single payer, then you have much better options. But what I was going to say is that in the European in the European Union, you can't take data from European Union citizens out of the European Union. So that's what I'm saying. I could not get access to that data from here. That's what I meant by I don't have access to the data. So okay. And then the other question is, what are the usage patterns? So what we found is that if the provider placed their first diagnostic order, so this is what we found was the marker for difference, was the first diagnostic order. So the average time in the emergency room, emergency department was, and I don't remember exactly, but it was like around 8 hours, something like that first day, 9 hours, roughly around that time. So what we found was that, these are preliminary results, that if the first order was placed through the care set, that for women, it shortened the length of the emergency room stay, and there was a significant difference between the male and female emergency room stays. Women had longer stays. Part of it was they were typically seen, men were seen sooner than women in the emergency room. So there may be some attention bias that's going on. The predicted length of emergency room stay was 55 weeks shorter. I'm sorry, 55 minutes shorter. Shorter when the first order was placed with the care set. And that actually brought it down to the average for men. Okay, so brought within a few minutes of the average for men. So pretty significant difference. And then also, this did lower costs for both men and women. And again, these are statistically significant results. So the predicted cost were reduced by 14%. What we found was that the first order was placed faster. We found some specific order types, some specific diagnostic orders that were placed more consistently. And so basically, the conclusion out of this is that we get an increased standardization of service delivery. And we saw this in the mix of what was ordered. Among the top 10 orders with care sets, there was a remarkable amount of consistency of what things were ordered. For the ones that were not ordered from care set, there was quite a bit more variation on what types of diagnostic orders were ordered. And then part of what was quite interesting here was that we saw that there were some statistically significant differences in male and female, and those differences seem to be quite dissipated. One of the things that we don't really know here is that this particular care set, there was a care set for women and a care set for men. Okay? So we don't know with these gender differences if it was just like that the care set was better, or if, we don't know from that standpoint what the exact nature of the gender differences is, because the care set and the gender are tightly tied together here, because they have abdominal pain men, abdominal pain women are the two major care sets for abdominal pain. But still, the results are striking. And to tie it back to this big picture, okay, I'm changed the chain here slightly, but it's a similar concept. Okay, if you have electronic health records, add computerized physician order entry, evidence-based care guidelines, implemented through the system, computerized care sets, what we're showing here is that this really can lead to better health outcomes at lower costs. Okay? So, and this is something that we've been largely taking on faith.
Just curious,
Yeah.
you looked at whether people where they used the order set, did they end up with more orders or fewer orders?
Two more orders per patient on average.
More orders?
Yes,
So
more orders.
Does that translate into more cost?
No, the costs were lower. Just like I said, the costs tended to be lower, even though they had two more orders. What we found was actually there was two specific orders that were low-cost diagnostic orders that got placed that took about an hour each, that are kind of broad-based screening orders that are good to do. And what happens is that, just anecdotally, what we found was that if people didn't remember to do them, they tended not to do them because they didn't want to hold up the patient in the emergency room.
Could you go back to that other slide? These are fabulous data, fascinating findings. So would one interpretation be that the clinicians were a bit sloppier, perhaps, in diagnosing women because there were other issues that could be considered, and this guided them to be more focused in their diagnosis or diagnosing of women? In terms of less time, it's less time in the ED, right? So that has nothing to do with cost because we don't pay the patients to be in the ED. And it could be that less time in the ED meant lousier medicine or better medicine. And we don't know that, except that there were lower costs. But we don't have ultimate data on whether they left the ED healthier and better guided or not, correct?
Well, so I have also data about whether they were admitted for inpatient, and I also have data about whether they were, what their length of stay in the hospital was once they got there. But I don't have that prepared to present today. And one of the real issues we ran into was interpreting whether that meant they had better care or not.
Right.
But what I would say is that I think one of the things that happens is that being more likely to be admitted might actually be a positive outcome because it reduces the barrier to care. Right, because the barrier to care might be that they weren't being admitted when they actually had a medical problem.
Yeah.
But yeah.
So I'm just thinking as an epidemiologist, is this
Right.
something as a problem, just classic confounding by indication? Those individuals who are exposed to care sets are in the perception of the clinician easier to manage. I'll just let the care set take care of them. Thus, they were going to be have your lower outcome anyway of costs anyway, because we reserve the care sets to the patients that we think are the easiest to take care of, and we just want to put them on
Okay,
automatic.
so great question.
And that
Right. So we control for acuity.
Okay.
So
Wow.
How did you control for
well, because we have acuity, and what we find is that the acuity is measured when somebody enters an emergency room. So it's a field acuity is the standard field in emergency room practice.
Sorry, I'm not familiar with it.
So acuity is used. So acuity, you've got urgent, emergent, patients about to die. Yeah.
Okay.
Right. I mean, there's like 5 settings. We took the bottom 2 and the top 1 away because they were so rare. So we were left with 2 and 3, which were urgent and emergent. Is what they call them there. And the thing is, they have very strict guidelines around how those scoring are, and they go back all the time and look like, did we have the right percentage? Did the outcomes match our scoring? Are we using those consistently? And we found no associations with that. So we tried to control for that. We controlled for age. We controlled for these other things in as much as we could control for.
But the question is, are they getting? Well, there are many questions, but one is, are they getting faster care because it's easier to check off care set L rather than pick the various tests and diagnoses? So it's sort of solipsistic in the sense that you've made CPOE more efficient, right, by using care sets. Or are they getting better care, or are they getting faster care? And those are great questions, but we're left with them.
Yes, we are, and I think we are out of time at this point. So I will leave you with some final thoughts, which is that in terms of secondary use of data, what I'm hoping you have as a takeaway is that there's many, many promising applications, but significant challenges that remain. And I imagine we could get together in 5 years from now and have a very similar set of challenges and opportunities. This is going to be an ongoing journey with issues and challenges that are not going to be solved overnight. Electronic medical records is really a necessary step. If we want to catch up with the Europeans, we've got to start gathering data in standardized ways, and then get some good governance structures like things like escrow accounts where we can get data and have them with enough contextual information that they can be meaningful, and have them in ways that are standardized to be useful. And then I just also want to place in mind here that way down the line, and maybe sooner, hopefully rather than later, once we have these sets of technologies in place, so emergency medical records, computerized physician order entry, along with things like care sets, right, that increases the standardization of care. As we have standardization of care, then we can start to see, well, okay, if these people are all on the same kind of protocol, that reduces one set of variation, then we can start to more quickly start to see, well, is that a good protocol or not? Okay, right? Then we can start using that secondary data, analyze it, and feed it back in, right? As a physician who I was talking about this results with said, I'd much rather have everybody in my department following the care set, and then finding out there's a mistake in it, because I can immediately correct that mistake, right? Other than, if I've got one person that's freelancing and they're doing something wrong, and maybe I never find out, right? Or it's going to be really hard to find that out. So at least then when we have this standardization of practice with this kind of system, it becomes a lot faster to get that kind of feedback loop in for quality and correcting with that. So thank you all very much for your time today.